welcome everyone. I'm going to turn it over to Dr. Friedman.
Hi, everyone. Welcome in the evening here. I'm Steve Friedman. I'm at Beth Israel Deaconess in Boston, Boston Children's Hospital, Harvard Med School, and I head up our Pancreas Center at Beth Israel. And it's great having everyone here. And we're going to have two presentations, and I'll be introducing Dr. Chris Forsmark in just a moment. So our format is 20-minute presentation, and then 10 minutes will be discussion, and then we'll turn it over for the second presentation, the second moderator. And as you develop questions during the presentation, towards the end, just put them in the chat, and then at the end of the presentations, we'll go ahead and go through the questions that are in the chat box and anything else you want to discuss. And on that note, it's an honor and great privilege to introduce Dr. Chris Forsmark. He's professor of medicine. He's chief of division of gastroenterology, hepatology, and nutrition. I've known Chris for many, many years. He's a phenomenal clinician, but also does amazing research, especially in acute and chronic pancreatitis. And his work in chronic pancreatitis has spanned from how do you diagnose this, including the role of secret and pancreatic function testing? What about symptoms? For example, pain, does it correlate with imaging abnormalities? And then treatments strategies as well. And Chris is funded from multiple sources, AbbVie, I believe, but also from NIH and the consortium. And I'm happy to turn it over to Chris.
Thanks, Steve. Can everybody see my screen okay?
Perfect.
All righty. So welcome, everyone. I see some names I recognize. So welcome to you as well. And thanks for inviting me. A great, I think I'm looking forward to the next lecture even more than you might be looking forward to this one. So it's going to be, I think, fun. So I've been tasked to talk a little bit about nutrition management with a focus on exocrine pancreatic insufficiency being the main driver of malnutrition in patients with chronic pancreatitis. So you heard my disclosures. I will strive to make sure these do not influence anything I say this evening. So when I was sort of thinking about this talk, there are, in patients with chronic pancreatitis that develop malnutrition, there's lots of drivers that produce malnutrition. In the left, we have sort of the one we're talking about mainly, which is they may not digest or absorb nutrients effectively, and EPI there on the left is exocrine pancreatic insufficiency, and they get other diseases which can interfere with absorption, like small intestinal bacterial overgrowth. There are a variety of other contributors to malnutrition that may be playing an important role in individual patients. They do have an increased resting energy expenditure. If the alcohol is a major cause of their pancreatitis, that may sort of displace food in terms of their caloric intake. They have a variety of other contributors: abdominal pain, food avoidance, poor activity, social isolation, smoking, those kinds of things that might drive it. And probably a very important but maybe underappreciated contributor is the chronic inflammation in the gland. And like many chronic inflammatory conditions, it's associated with significant issues with nutrition. And these all sort of combine to produce malnutrition, but the consequences we're mainly interested in are specific nutrient deficiency, and in these patients, particular vitamin D deficiency leading to osteoporosis and bone fracture, but other important consequences as well, like muscle mass loss. And it's definitely associated with a reduction in quality of life and with increased mortality, actually. So malnutrition is an important concept to think about in these patients with chronic pancreatitis, and it's due to a variety of contributing factors. We're going to focus on one of the important ones tonight, which is exocrine pancreatic insufficiency. So when we think about exocrine pancreatic insufficiency, there's a variety of patient groups that are at high risk for developing this. And we're talking mainly about chronic pancreatitis at the top there. There's probably around 200,000 people, maybe a bit more in the US. And somewhere in the neighborhood of 30 to 50% of these people have exocrine pancreatic insufficiency. And it depends on what caused the chronic pancreatitis and how long the patient has had it. And the upper right is just some average time to onset of exocrine pancreatic insufficiency. And you can see that in patients with alcohol-induced disease, it's shorter than with other forms of disease. There are certain etiologies or particular drivers, and the longer a patient's had chronic pancreatitis, the more at risk they are. We know that in patients with cystic fibrosis, the vast majority of these have exocrine pancreatic insufficiency, often beginning at birth. People that have had pancreatic resection for benign or malignant disease commonly get it. And many patients with pancreatic cancer get exocrine insufficiency. The CT on the left is sort of a patient with pancreatic cancer, and you can see sort of the dilated pancreatic duct and the atrophic gland upstream of it. So these folks get exocrine insufficiency both due to atrophy as well as ductal obstruction. And then there are some additional risk factors. The CT on the right is a patient with bad necrotizing pancreatitis where a lot of the gland has been destroyed. So we have kind of a list of people and disease states that are likely to be associated with exocrine pancreatic insufficiency. There's also a whole nother list of diseases which may or may not produce exocrine pancreatic insufficiency. And the question mark is that sometimes it's hard to figure out if they've developed exocrine insufficiency or not because we don't have very good testing. So an example might be somebody with acute pancreatitis or relapsing pancreatitis, but who hasn't destroyed a lot of the gland at acute from their episodes of pancreatitis. And the graph on the right is looking at the prevalence of exocrine pancreatic insufficiency in patients that had severe acute pancreatitis, which we kind of expect. But even in patients that have mild pancreatitis, you can see that there's, if you look long-term, maybe 1 in 5 actually ends up with long-term exocrine insufficiency. So that's a group we may not think about a lot, but in whom exocrine pancreatic insufficiency can occur. Another big category might be diabetics, and you'll hear a lot about diabetes and pancreatitis in the next talk, but there's a wealth of information on people with long-standing diabetes, type 1 or type 2, that appear to have at least some increased risk of getting exocrine insufficiency. And there are a variety of other conditions I've listed on this slide, which can be associated with exocrine insufficiency. And if you go to the internet and sort of look this up, what you'll mainly see is on the sort of bottom right, which is, if you have bloating, if you have dyspepsia, if you have gas, you probably have exocrine pancreatic insufficiency and you should talk to your doctor about it. So there's a lot of sort of direct to patient advertising about this, but it can be challenging sometimes to know if somebody actually has exocrine insufficiency. And the challenge is really based on the fact that we don't have good testing. So there are a lot of ways that have been developed over the years to try to diagnose exocrine pancreatic insufficiency. One way we used to do it is just try to measure digestion, typically of fat. And you can do that by collecting stool in somebody with a known fat intake. So this is the infamous 72-hour fecal fat. That's the buckets up on the right there. As you can tell from, if you try to collect a patient's stool over 72 hours, it's unpleasant for the patient, the doctor, the staff, and the laboratory. So really, this is no longer done outside of perhaps rare clinical research. And doing that test just proves the patient's not absorbing fat. It doesn't tell you why they're doing it. It doesn't prove that it's pancreatic insufficiency. There are some tests which try to measure the actual enzyme-specific digestion, generally of fat. There's some blood tests and some breath tests. An example is those graphs on the middle section on the right, where you can see by measuring the metabolites of fat digestion, you can begin to estimate pancreatic digestive capability. These are attractive, but they're not really available for clinical use. And the other way is just try to measure how much is coming out of the pancreas in the way of enzymes, either by putting a tube down, which is the lower right, which is difficult to do, or more commonly by just collecting stool and measuring the enzymes that are present in the stool, which is essentially the test we have to do this. And the test we use is fecal elastase. It's a digestive enzyme produced by the pancreas. It's not actually elastase, although we call it elastase. It's a related enzyme. And so we have some cutoffs. If there's a very low value in the stool, then that might be consistent with the pancreas producing inadequate enzymes for digestion. And there are various cutoffs, either less than 200 or less than 100. If you look at the package insert, it says less than 200 is consistent with exocrine pancreatic insufficiency, but I think that's not actually the case. You really have to get to fairly low levels, less than 100, before you can have any confidence in it. It's less accurate in children, and although it's been compared to tests like pancreatic function testing, the PFT on the slide there, or fecal fat testing, and the numbers look fairly good. The challenge is that if you use the test in a low prevalence population, like people who have bloating or gas or dyspepsia, there's a significant false positive rate. So it is something to watch out for when you're trying to make the diagnosis with elastase, and that is that a lot of patients that have a low elastase do not have exocrine pancreatic insufficiency. Just a few caveats as you use it. Remember that the stool sample has to be solid or semi-solid, because if it's real watery, that dilutes the elastase and gives you a falsely low number. You don't have to stop the pancreatic enzymes when you do the test. I test almost always more than once, and I've noticed that it's quite variable. So I like to have consistency in the test results. And the other thing that's important is just because you have a low elastase doesn't mean you have exocrine pancreatic insufficiency. It takes the right setting, the right symptoms, and there are certain diseases like age and diabetes which seem to affect it significantly. If you look at a lot of the reference labs, actually fecal chymotrypsin is commonly ordered as well, and it's far less accurate. So if you are going to do stool testing for elastase, for exocrine insufficiency, don't use chymotrypsin, use elastase, because chymotrypsin is even less accurate than elastase. So one of the challenges, I think, is when you don't have a great diagnostic test, you would at least like some consensus from the experts about what the cutoff should be and how to go forward once you identify a low elastase. This is part of an international survey of a bunch of experts across the world, and they ask them, what cutoff do you use to diagnose exocrine pancreatic insufficiency? And you can see the percentage of respondents that identified various cutoff levels. And it's obvious, I think, that there is no consensus on what cutoff we should use. The experts were asked if the level of elastase influences what dose they use when they're replacing enzymes, and the majority said it doesn't. And then they had a series of vignettes, which were treatment vignettes, and there was even significant disagreement. So one of the major challenges in this condition is that it's hard to diagnose, and there's not really a consensus on exactly how to diagnose this and how to treat it. So what you're hearing from me is sort of my opinion, but it is my opinion because there's not a lot of evidence to support these expert opinions. So moving to treatment now, I mean, the reason we want to treat these patients is obviously we want to avoid malnutrition, but there are some specific consequences in these patients that we would like to avoid. They often have steatorrhea. Steatorrhea is not dangerous, obviously, but it's interesting to know they usually don't have diarrhea, so they can have massive fat loss and fat-soluble vitamin loss without actually complaining of diarrhea. They may get weight loss, although many patients with chronic pancreatitis and exocrine insufficiency are actually overweight. What they really get is muscle loss. So they get sarcopenic obesity. So they have muscle loss, but maintain BMI and fat. It can make a major problem for the endocrinologist in trying to manage the concomitant diabetes. And you'll hear from Mark in just a little bit about some of the challenges of managing it. One of the main things they get is osteopenia and osteoporosis, and they get it at a rate which is equivalent to IBD or celiac disease, or even a bit more. and they get a lot of low trauma bone fractures as a consequence. And they can certainly get a variety of deficiencies. Vitamin D is most common, but they can get deficiencies in other fat soluble vitamins and micronutrients, and occasionally even in B vitamins. The patient on the lower right there is a patient of mine with pellagra as a consequence of chronic pancreatitis. And it definitely has a variety of, I think, more important quantitative poor outcomes like increased hospitalization and reduced quality of life. And at least in chronic pancreatitis and some of the data in pancreatic cancer, excess mortality as well. So lots of reasons that we would like to be able to identify and treat this in patients with chronic pancreatitis. So at least when I'm treating somebody where I'm going to initiate exocrine, when I think they have exocrine pancreatic insufficiency, and I'm going to initiate pancreatic enzyme replacement therapy, these are some of the baseline studies that I tend to do, at least in my clinic, to get a sense of where we're starting. I do some anthropometrics, which at least for me is a BMI, but it's also some estimate of muscle mass or strength. So all of these folks have had a CT, so I look at their muscle mass at the L3 level, particularly the psoas is helpful. And sometimes we'll do simple testing of muscle function, like hand grip, or a timed up and go test, which is available at the CDC. It's a simple thing you can do to measure sort of a muscle function. I do get some basic nutritional parameters and vitamin levels. I think a hemoglobin A1C is prudent to get in these folks because they also get diabetes. And then on the right are some of the things that you might not think about. I think I get a DEXA scan, and anybody I think has exocrine pancreatic insufficiency as a baseline. Many patients do not get a baseline DEXA scan for osteoporosis. I refer them specifically to a smoking and alcohol cessation program. And I encourage sort of increased physical activity as a way to sort of preserve bone in these folks as they age. So this is just my list of baseline parameters, and I tend to monitor these over time to make sure they're improving. So when you start to treat these people, obviously you want to make sure that they need treatment, which means you need an accurate diagnosis, and that can be challenging because our diagnostic testing is imperfect. The general rule of thumb is you need about 10% of normal pancreatic output to have normal fat and fat-soluble vitamin absorption. So a normal pancreas makes in the neighborhood of 900,000 USP units per meal. 10% of that is 90,000. You don't often need to start at 90,000 because the pancreas is still making some enzymes usually, and there is a gastric lipase that can partially compensate. But most guidelines say start at 40 to 50,000. They should be taken during the meal and during the snack. Remember that the enzymes are treating the meal, so they have to be given with the meal. And for pediatrics or small people, you can weight base it as well. And I certainly think, again, you should measure and supplement fat-soluble vitamins. And again, I'll make another plea for measuring bone density because I think it's not done as frequently as it should be done. There are a variety of products which are available in the US. They're identified by the lipase content per meal, which is in the column on the right, so different strengths. But they obviously have proteases and amylase in them as well, but this is the lipase content. The majority are enteric coated, so they release at a certain pH, generally in the proximal small bowel. There is one product which is not enteric coated, so it releases more proximally. If you're using that one called Viacase, you generally need to be on something to reduce stomach acid so the enzymes aren't denatured by acid. But you can look at the numbers and you say, well, if I need 40 to 50,000, depending on the strength you're using, you can add up how many pills the patient needs to take. It's interesting that the products don't actually fully correct steatorrhea, no matter how you use them, it appears. This is just some data from a meta-analysis, and the numbers on the far right are the ones to sort of pay attention to, which is if you compare what's called the CFA, which is the coefficient of fat absorption, that's how much of the dietary fat is absorbed. It's much better if you're on pancreatic enzyme replacement therapy compared to either the baseline or placebo, but it never corrects completely. Normal would be around 93% or above. So the enzymes are good. They're just not as efficient as a normal pancreas. So even when sometimes when you get to 10%, the 90,000 per meal, you're still not getting complete absorption just because the products can't really mimic what a pancreas can do. So one question is, if we know some groups of patients who are highly likely to have exocrine pancreatic insufficiency, the question is, well, at least in the US, are they tested for exocrine insufficiency? Are they treated for exocrine insufficiency? And the general, I think the studies from both Europe and the US have shown that that's not actually the case. This is just one study I'll show you, which is a study I did with Diraj Yadav, and we were looking at people in the US that had health insurance. So that would presumably be a group that had access to enzyme therapy, pardon me. But in that large analysis of 37,000 patients with chronic pancreatitis, only about 6.5% even had any testing for exocrine pancreatic insufficiency. Interestingly, about a third received a prescription for enzyme replacement therapy, but only about a third of those got a prescription that was at what we were considering a minimally appropriate dosage, which is 40,000 units per meal or more. So only about 1 in 10 chronic pancreatitis patients in the US was on at least an appropriate dose of enzyme replacement therapy. And again, the data would suggest that 30 to 50% of these patients have exocrine pancreatic insufficiency. And this mimics data really from Europe as well, where although sometimes we kind of know what to do, we don't do it very well. So the other thing that really comes up from patients a lot is dietary recommendations. And there's really not a lot of science that informs us. Most recommendations are for low-fat diets. Many patients seem to tolerate low-fat diets a little better. Many recommend multiple small meals. This is, I'll make a pitch for the National Pancreas Foundation, which is our cookbook on the right. These are not scientifically based recipes, but they're recipes from patients and their families with chronic pancreatitis that they found they can tolerate. So this is available for free download if you have any patients that want to read some tried and true recipes from patients with chronic pancreatitis. You should avoid the very low fat diets just because they're more likely to get fat soluble vitamin deficiency. Sorry, I needed a sip of water there. If you read textbooks, they also mention MCT oil, medium chain triglycerides, which I've never used in 40 years of practice, but it still populates textbooks. And again, don't forget calcium and vitamin D. So when you're treating those folks, how do you know it's even working? So generally, you're looking for a clinical response. Did the steatorrhea get better? Is their strength and energy improved? Is their muscle mass improved? Are their fat-soluble vitamins improved? It doesn't really make any sense to remeasure. We really don't measure fecal fat to begin with, so it's not useful to measure it again. Fecal elastase doesn't tell you anything about whether it's working. And my experience is a lot of the non-specific symptoms like bloating and dyspepsia and gas are pretty unreliable markers of whether it's working. So I look at the stuff on the left when I'm trying to figure out, is the dose right? Should I push the dose? Or is this sufficient? Patients may not respond in the way you anticipate. One of the most common reasons, at least in the US, is they're not taking the right dose or they're not taking it at the right time. Around a third of prescriptions are not even filled in the US because of cost. And the instructions that patients get are often, I have many patients that come in and they've been told to take it 3 times a day. So they take it when they get up about an hour before breakfast. They take it, an hour before lunch, and they take it when they go to bed. So if the enzymes don't mix with the meal, they don't have any effect at all. So just the instructions have to be take during the meal. That's how they should be written. And if that's not the case, if they're on the right dose, if they're actually taking it, if they're taking it in the right way, that's when you can consider looking for alternative diagnoses, and probably small intestinal bacterial overgrowth would be the most common. There are some special circumstances for pediatrics. I put the weight-based and age-based if you need that. Some of these folks need tube feeds. If you give them an elemental tube feed, they don't need enzymes, or you can use Relazorb, which is the immobilized lipase. And if you need to supplement, they need more calories or they need more fat. Incala is much more tolerated than MCT oil, so that would be the product to use. So just to finish up, I think exocrine pancreatic insufficiency is common in some populations we can identify. At least in the US and in other countries, a lot of the patients that are at risk aren't tested, and many are not treated. If they are treated, they may be treated inappropriately. One of the challenges for all of us is we don't have a widely available and accurate diagnostic test. The best we have is clinical suspicion and a fecal elastase. And then once you've made a diagnosis, do some baseline nutritional parameters. You can use the list I use or one of your own. Start with an appropriate dose, make sure it's given during the meal, and then determine what you're going to measure for efficacy, really based on clinical features. And then if it's not working, push the dose. You can go up to 90,000 without risk. Again, don't forget about osteoporosis and osteopenia. And if they're not responding, it's usually not a different diagnosis. It's usually inadequate dosage or wrong timing. So thanks for your attention. My manatee will hopefully not have to wear his mask for too much longer, but happy to take any questions.
Chris, thank you. That was great. Feel free to put questions in the chat box, or you can raise your hand if you want, and I'll, electronically, and I can see that. Maybe while people are pondering things, Chris, is it reasonable to just try pancreatic enzyme replacement therapy in a patient that clinically is having steatorrhea and just see the response? And if you're responsive, then it's both diagnostic plus it's therapeutic at the same time, or should we be getting elastase levels in the stool?
Yeah, I mean, if elastase was highly accurate, I could come down strongly on the side of elastase, but it's not. And so I think if you have a patient in the clinical scenario is suggestive to you that disease is likely, I don't have any objection to an empiric trial, as long as you're sort of looking at the right outcomes. You're not looking, well, they had gas before and they don't have gas now, so it must be working. If you have some more quantitative outcome you're looking at, maybe it's visible fat in the stool, or maybe it's muscle mass, or maybe it's weight, or whatever it is, but as long as it's semi-quantitative.
Other questions?
I have a question for Chris too. So one of my long-standing questions in this field is, why does it have to be a dichotomy, you're sufficient or insufficient? Don't we have actually a continuum of degrees of insufficiency, and maybe the fecal elastase cutoff point should reflect, those different degrees of severity? And maybe that's why that survey gave different numbers, because people have, their mental cutoffs about the severity of the disease at different points.
No, I think that's an astute point. I mean, I think that, so I have a patient who has had a total pancreatectomy, so they don't have a pancreas. It's more than 10 years ago. They don't take pancreatic enzymes at all. They have a normal weight, normal activity, normal fat-soluble vitamins, and they feel fine. And so does that patient have exocrine pancreatic insufficiency? It seems, well, of course, they don't have a pancreas. How can it be otherwise? But the other question, the important question is, well, is it so impactful that they need treatment? And humans have a lot of salvage mechanisms for absorbing fat and protein and amylase. So in some people, those salvage mechanisms work. So this patient, I mean, she has exocrine pancreatic insufficiency, but that doesn't necessarily mean she needs treatment. You know what I'm saying? Mm-hmm. So that's the big question as well, is when do you have to treat people? And that's a question for another day, I think, because I don't know the answer.
I think on the flip side of that question, because I do think it is a continuum. It's not, you have to knock out 90% and then all of a sudden you have EPI. There's at least one paper out there. You just look at healthy people over age 50 that, again, I'm not sure it's the best output. They looked for exocrine pancreatic insufficiency, and I think found like 5 to 10% of people have some degree of EPI who are otherwise healthy.
No, it's like you take EUS and you start looking at everybody's pancreas, and guess what? There's a lot of wear and tear on your pancreas from normal living, and it doesn't look normal when you get 50 or 60, and it might not work normal, but it's works kind of enough.
Exactly.
Enough that it doesn't need treatment.
There's no other questions. I want to thank Chris. I know it's a little after 8:30 now, and let me turn it over to you guys to take over the second half.
Sure. So I am thrilled to introduce the next speaker tonight, Dr. Mark Goodarzi from Cedars-Sinai. And just for those that logged in late, the format is a 20-minute talk followed by 10 minutes for questions and answers. And if you have any questions, please post them to the chat so that we can go over them later. Dr. Mark Goodarzi is Professor of Medicine and Biomedical Sciences at Cedars-Sinai Medical Center, and he's the Director of the Division of Endocrinology, Diabetes, and Metabolism. He's also Director of the Endocrine Genetics Laboratory and the ARIS Field Chair in Diabetes Research. Dr. Goodarzi's lab seeks to identify genetic factors related to insulin resistance and diabetes using a population genetic approach. His special areas of interest have included atherosclerosis, polycystic ovary syndrome, and pharmacogenetic studies on the glycemic response of statins, and GLP-1 agonists to prevent diabetes. Dr. Goodarzi has published extensively in these areas, but also in chronic pancreatitis and diabetes. In this specific area, Dr. Goodarzi leads the Type 3C diabetes working group within the NIH-funded consortium for the study of chronic pancreatitis, diabetes, and pancreatic cancer. And he's also a member of the Type 1 Diabetes and Acute Pancreatitis Consortium and the PI of one of these clinical sites of this consortium. I know Mark very well from our collaborative studies in these two consortia, and I'm familiar with his research in the area of chronic pancreatitis, and that's why I'm thrilled to have him here tonight. I look forward to his talk, and I'm sure you in the audience will also enjoy his talk too. So without further ado, Mark.
Thanks for the introduction, Fred. It's a pleasure to be here. Everyone can hear me and see the slide? Everything ready to go? All right, great. Okay, so I'm going to be talking about endocrine complications of pancreatitis, focusing on chronic pancreatitis, but a little bit on acute as well. There's my disclosure. So pancreatic diabetes, you may have also heard of this term type 3C diabetes. I certainly remember the first time I heard that, I thought, what? Did I miss something? But here's where it came from. This is a table that the American Diabetes Association used to publish every year. This is the last time they did this in 2014. And I think basically what happened is someone took the table a little too literally. So you see Roman numeral 1, type 1 diabetes, Roman numeral 2, type 2 diabetes, and Roman numeral 3, we have other types, and you see diseases of the exocrine pancreas down here under C. So someone took this a little too literally and started calling it type 3C diabetes. It's certainly not an official designation, but it's kind of stuck, and it's out there in the literature. So we use this terminology, essentially referring to pancreatogenic diabetes. But you can see here, there are many potential causes of pancreatic related diabetes. So, we're trying to, I don't think that the pathophysiology is going to be the same for each of these. And we're trying to refine this a little better through our research in our consortia. So here's an early paper where we review the literature and at least try to divide things by absence of islets or dysfunction of islets or a paraneoplastic syndrome. I'm not going to be talking about this tonight, but pancreatic cancer seems to cause diabetes through a paraneoplastic mechanism. So we'll hopefully have better terminology for this once we understand these conditions a little better. So here's the epidemiology of this. So starting with the pie chart on the left, this is all of diabetes. And some studies have actually found that diabetes, I'll just call it type 3C to save time tonight. Type 3C diabetes is actually more common than type 1 in adult populations. So if we then focus on type 3C diabetes, you'll notice that 80% is post-pancreatitis diabetes, with pancreatic cancer coming in at about 18% and cystic fibrosis at about 2%. If we then focus on the post-pancreatitis diabetes, here we come to the last pie chart, and this is a fairly recent realization. You know, it used to be thought that chronic pancreatitis was the most common cause of type 3C diabetes, but in fact, it's actually post-acute pancreatitis that leads to the majority of cases of post-pancreatitis diabetes, with post-chronic coming in at 17%. So pretty dramatic recent realization, which has actually spurred a new consortium sponsored by the NIH to try and understand that. And you see incidence rates on the bottom there based on primary or tertiary care setting. But again, acute pancreatitis is now considered the most common cause, causing 2/3 of type 3C diabetes. Here's a very practical algorithm for making the diagnosis, published by some of our colleagues. So you suspect the disorder in an adult who's had pancreatitis. You measure their A1C and fasting glucose. If they have autoimmune markers, it's type 1 diabetes. If they don't have that, you look at their chart, you look at their history. Did they already have known diabetes before the pancreatitis? If so, it's type 2 diabetes. And then here, looking at the A1C, remember A1C reflects the last 3 months of glycemia. So if the A1C is already elevated close to the time of pancreatitis, then you know they already had diabetes. You go to type 2. If that A1C is not elevated at the time of pancreatitis or is unknown, you look at their fasting sugar. Now, that certainly may be stress hyperglycemia if it's very close to the event of pancreatitis. But if 3 months out, they develop an elevated A1C or still have an elevated sugar, now we can diagnose post-pancreatitis diabetes. And then you divide that by post-acute or post-chronic. So you'll see this is a very practical algorithm, but you'll notice it doesn't rely on any specific biomarkers, which is a great need in the field. It's really nice to see increasing recognition of this condition, and now, you know, Diabetes Care, which the highest impact journal in diabetes, is over the last few years has been publishing several of these papers. So it's great. It's going to bring greater visibility to this condition. But here's one of the first really landmark studies in diabetes care, looking at across multiple UK primary care practices about 32,000 new diagnoses of diabetes in adults. And this is largely where the prevalence estimate comes from. 1.8% of these cases occurred after a pancreatic disease. And that's either acute or chronic disease. And here's the breakdown of the chronic pancreatic disease. And you see chronic pancreatitis is the most common, followed by hemochromatosis and cystic fibrosis. And only 1.1% were considered to have type 1 diabetes based on autoimmunity. They then followed these patients over time. And really quite dramatic was their progression to needing insulin. So you see type 1 diabetes at 5 years out, only 4% needed insulin. That's the blue line here, freedom from insulin. Post-acute pancreatitis, at 5 years, 20% needed insulin. And after chronic pancreatic disease, 46%, and chronic pancreatitis, 42% needing insulin. So you see a much more rapid progression to needing insulin in chronic pancreatic disease versus type 2 or post-acute pancreatitis. Another thing that this paper looked at was, you know, how are these patients classified? And pretty depressing to see that only 2.7% post-pancreatitis diabetes were actually diagnosed that way. About 90% were diagnosed as type 2. Furthermore, those with pancreatogenic diabetes had worse glycemic control. They had higher A1C levels. A separate study looked at these patients and found that compared to type 2, those with CP-related diabetes had a 5-fold increased risk of severe hypoglycemia. So this is not trivial. This This was severe hypoglycemia defined as severe enough to require hospitalization. So hopefully I've convinced you that you don't want to miss this diagnosis. They have worse glycemic control, they progress to insulin quicker. You want to know this when you're treating these patients so you can monitor them closely and go ahead and give them insulin if their A1C starts creeping up. Furthermore, as Chris alluded to, they'll often have malabsorption, and you want to treat that. So, at least the first time you see anyone with diabetes, get that history. Have they ever had acute or chronic pancreatitis? Now, this has other consequences. CP-related diabetes, they're at a 34-fold increased risk of developing pancreatic cancer compared to healthy individuals, and a 12-fold risk compared to people with type 2 diabetes. Diabetes following CP, also in actually multiple studies, has been associated with a 30 to 50% higher all-cause mortality risk compared to type 2. And interestingly, it wasn't cardiovascular death or renal death. The causes of death seem to be respiratory, infectious, and of course, GI. And a higher cancer mortality in women with CP diabetes has been documented. They have higher morbidity as well compared to type 2. They have higher rates of hospitalization for gastric ulcer disease, reflux, chronic pulmonary disease, renal disease, and infections. So what we really need are specific biomarkers to allow us to detect these people and distinguish them from the much more numerous type 2 diabetes. And we're certainly working towards that in our various research efforts. So here's a study from the North American Pancreatitis Cohort, or NAPS2, a cross-sectional study over multiple centers, about 1,200 patients with chronic pancreatitis. I'm trying to ask, what clinical features can we use to see if they have a higher risk of diabetes in CP? Now, in this study, diabetes was based on questionnaire, so just keep that in mind. They looked at multiple values, and in fact, this study was really nice because they went beyond pancreatic risk factors. It was a pretty extensive exploration. And here in a multivariate analysis are the significant factors. So that remained significant after controlling for the other factors. And you see the most significant factors here were obesity, a 2.8 odds of diabetes, and exocrine insufficiency, a 2.4 increased odds. So you see on the graph here, if you have both obesity and exocrine insufficiency, almost 60% of those patients had diabetes. So the interesting feature here is that sort of classic type 2 diabetes risk factors like age, male sex, obesity predict diabetes and chronic pancreatitis, but also so do pancreas-specific factors. And this is a review of the literature, and the factors I'm showing here were observed in at least 2 studies. So the duration of CP, the age of onset, biliary stricture, exocrine insufficiency, alcoholic etiology, surgery, and calcifications were all risk factors for diabetes and chronic pancreatitis. So the authors of this study propose, with this mixture of factors, maybe you've got patients who are kind of on the path of type 2 diabetes or diabetes, and then they get a second hit from the pancreatic disease. It could also be that patients in that study, had a mixture of etiologies. So I decided to look at this from a genetic standpoint. As Fred just told you, I'm a geneticist at heart. So what we did was we took the NAPS2 study and also the multi-ethnic study of atherosclerosis, or MESA, and essentially, looking at various types of patients in these 2 studies, came up with 3 groups. A group with type 2 diabetes and no pancreatic disease, a group with no diabetes and no pancreatic disease, so our controls, over 3,000, and a group with chronic pancreatitis-related diabetes. And then we then genetically profiled them. And what we did, the concept here is a genetic risk score. If you can aggregate genetic variants, you can actually distinguish different forms of diabetes. So this has been well demonstrated. For example, genetically, type 1 and type 2 are very distinct. And similarly, type 1 diabetes and maturity onset diabetes of the young are genetically distinct. So the premise of the study was if CP-related diabetes is pathophysiologically distinct from type 2 diabetes, it should have a different genetic profile. And what we found was very much not the case of what I just told you. So here are the non-diabetic controls. So nice to see that genetically from what I didn't mention actually was our genetic profile was 60 robust, well-validated variants for type 2 diabetes. So as expected, the non-diabetics have a lower, a very significantly lower genetic risk score versus those with type 2 or CP-related diabetes. And what was interesting here was that type 2 diabetes and CP diabetes were identical genetically. And we did a series of sensitivity analyses. So for example, excluding from the group of CP diabetes those who had a family history, or excluding those who were obese. And in all of our sensitivity analyses, we saw the same result, that genetically, they were pretty much the same. So what does this possibly tell us? You know, from a diabetes genetic standpoint, CP diabetes and type 2 diabetes were similar. Now, maybe CP diabetes is simply a subtype of type 2 diabetes. If you think of the way we conceptualize the development of type 2 diabetes, you've got some predisposition based on genetics and lifestyle. You develop some insulin resistance. And then here's the gateway. If your beta cells can compensate and make enough insulin to overcome the insulin resistance, you remain normoglycemic. It's the failure of the beta cells that's the gateway to type 2 diabetes. So looking at CP diabetes, you know, perhaps that key compensatory step is compromised by the pancreatic disease, leading to an accelerated pathway to diabetes. So intriguing message from genetics. Now, finding that a genetic risk score for type 2 diabetes predicts CP diabetes, you know, this may one day help us clinically. You know, it could be a biomarker. A genetic risk score for diabetes variants, you know, may help us predict who with CP may develop diabetes in the future. Now, some caveats to this study, you know, we did not have a gold standard to diagnose pancreatic genetic diabetes. There may be other genetic variants specific for CP diabetes that we didn't look at. And in this study, the group that we called CP diabetes, you know, may be a heterogeneous group. There may be some type 2s in there affecting our discriminative capacity. And the sample sizes were not tremendous by sort of genetic standards. And remember, we were only looking at CP diabetes. So pancreatic cancer-associated diabetes may well have a different genetic profile. We haven't looked at that yet. So thinking about CP and diabetes, you know, this is a progressive disorder. You know, it's not, you know, before I got into this research, I used to think CP, sure, of course you have diabetes, your pancreas is dead and there's no beta cells. However, it's actually much more interesting. So well before you get into the end stage fibrosis, beta cell destruction, there is a fairly protracted phase where the islets are still there, and they often look morphologically normal, but they're dysfunctional. So something going on with the inflammatory milieu that's leading to beta cell dysfunction. So it's actually very interesting from a functional standpoint. It's not just a boring destruction process. Now, under this model, you would expect duration of the disease to lead to increasing rates of diabetes over time. And indeed, this is what we have seen. Various studies, I highlight a couple here that had very nice follow-up. So at diagnosis, about 4 to 10% had diabetes, a year out, about 8%, 10 years out, 30 to 50%, and 20 to 25 years out, you see the majority of patients with CP are going to end up with diabetes. And here's a meta-analysis of 15 studies and found that overall, 30% of patients with CP had diabetes, but duration was the main risk factor. So thinking a little bit about the pathophysiology, you know, we of course invoke insulin deficiency for obvious reasons, but there may be more to it. physiologic studies have actually documented insulin resistance in patients with CP and diabetes. Insulin resistance at the level of the liver may be a key feature related to deficiency of pancreatic polypeptide. There's been actually a study showing that administration of pancreatic polypeptide may improve glucose tolerance in patients with CP diabetes. And pancreatic polypeptide, possibly prematurely, has been proposed in several expert opinions as a biomarker that we could use to make this diagnosis. So we decided to look at this head on in a study that we call DETECT, where we're administering a mixed meal tolerance test in people with different kinds of diabetes. So let me show you some results that have been presented. So what we're doing in DETECT is we're giving a mixed meal tolerance test and looking at the hormonal responses. And you see here we're measuring the responses at multiple time points over 2 hours. And we're studying people with type 2 diabetes, CP-related diabetes, and pancreatic cancer related diabetes. And so you see here, type 2 diabetes here on the left, cancer-associated diabetes, and CP-related diabetes. And indeed, fasting pancreatic polypeptide is significantly lower in those with pancreatogenic diabetes, and it's the lowest in CP-related diabetes. Looking over the time course of the mixed meal tolerance test, we see quite dramatic in chronic pancreatitis related diabetes, the lowest levels, the lowest response, with pancreatic cancer related diabetes in the middle, and here's type 2 diabetes where you see a nice response. And this, we see similar result looking at the total area under the curve. Now, if we take into account the fasting level and look at the percent change, it's quite dramatic in the early time points, so 15 and 30 minutes after the meal. This is where we're really seeing the low response in our patients with chronic pancreatitis related diabetes. Less dramatic in pancreatic cancer related diabetes. However, you'll notice there's a lot of overlap. So it does not appear to have the capacity of a biomarker to fully distinguish these types of diabetes. What's the role of exocrine pancreatic insufficiency? As Chris was talking about, maybe this contributes to the hyperglycemia. So we have these hormones that we call incretins, GLP-1 and GIP, that the gut secretes in response to food ingestion, and it's a signal to the pancreas to make insulin. And there's a hypothesis out there that with the EPI, with the maldigestion, that perhaps might compromise the incretin response, and then that would then contribute to postprandial hyperglycemia. And in type 2 diabetes, it's been observed that beta cells remain responsive to GLP-1 but lose their response to GIP. In CP diabetes, some studies have suggested a similar pattern to type 2 diabetes. It's not entirely clear if what's going on with the incretin system. This needs more study. Now you can imagine there's very little enthusiasm for giving GLP agonists or DPP-4 inhibitors to someone with CP and diabetes, because those medications, if you look at the package insert, carry a possible risk of inducing pancreatitis. So what can we do for these patients? Well, maybe pancreatic enzyme replacement may then improve digestion and improve the incretin response. This has been very scarcely studied, only 4 small studies here, 2 in CP, 2 in cystic fibrosis. And while enzyme replacement does seem to increase the incretin response, as shown here, you'll notice the effects on insulin response and glucose response are quite mixed. So we need bigger studies in this regard. So wrapping up, we're still trying to figure out, is CP a distinct form of diabetes or a subtype or an accelerated form of type 2? We really need specific biomarkers to help us identify these patients so we can focus on them as far as their greater need for treatment and their risks associated. As far as the blunted pancreatic polypeptide response, it's certainly a feature of CP diabetes, but does not at the moment seem to have the discriminative capacity we would like to see. Larger samples may help us here. And we need future studies to understand the mechanisms underlying CP-related diabetes. And we need treatment trials. There's very little out there as far as how we can treat these patients. And that's it. Happy to entertain any questions.
Thank you, Mark. That was an outstanding talk. We have a couple of questions here in the chat. The first one is more of a operational, I guess, question. How can we access this session later?
Oh. Okay.
That question I'm going to defer to Margie and Jill, but I'm sure you can send that information out to the attendees.
I think we're being recorded.
It is being recorded, so we'll make sure that you get the information on how to watch it online.
The next question is, Dr. Darcy's research is fascinating. Has anyone looked at proinsulin pancreatic polypeptide or C-peptide in patients post-acute pancreatitis to predict diabetes later? We're familiar with that question, aren't we?
Yes, just for the person who asked it, the NIH is very interested in this as well. So we actually have a consortium of 10 clinical centers, and we are actually recruiting patients who have had acute pancreatitis within the last 3 months. And we're going to follow them very closely. We're going to be doing OGTTs in most of them. We're also we'll be doing meal tolerance tests and also IV glucose tolerance tests. And we'll be measuring all of these hormonal responses to characterize the kind of diabetes they develop and hopefully develop methods of predicting that. So your question is right on. We just launched the study a few months ago. So hopefully in a few years, we'll be able to come back and tell you what we find.
The next question is, why does type 3C diabetes has more hypoglycemia episodes compared to type 2?
So I can't tell you that it's definitively known, but the general thought is that the pancreas is sick, and remember the islets make other hormones. For example, glucagon, right, which we depend on to combat hypoglycemia. So the thought is that if the loss of glucagon, you're treating the patient with diabetes, you might be treating them with insulin, and they get a hypoglycemia. They don't get that ability to produce a lot of glucagon to combat that hypoglycemia. So that's part of the thinking, is that the deficiency of other islet hormones may increase the risk as well. There could be other factors, for example, being generally more ill or the malnutrition. So it's probably multifactorial.
And adding to that, exocrine insufficiency too, right? Because if you're not digesting carbohydrates and your insulin is kicking in the bloodstream, you're going to have a mismatch in early postprandial hypoglycemia.
Absolutely.
I have a question for you too. One of the things that has fascinated me about chronic pancreatitis is how many people with very damaged pancreas has no diabetes. So you showed, if you have obesity, if you have exocrine insufficiency, 60% have diabetes. But what about the other 40%? Their pancreas is shot, and yet they maintain normal glycemia. Contrast that with some patients that get 1 or 2 mild episodes of acute pancreatitis. You look at their CT scans, the pancreas looks intact, and yet they have diabetes. So any thoughts on why some develop and some don't? Besides, the genetic score, data, of course.
Yeah. As I mentioned, how robust your beta cells are, really is the key to whether you develop diabetes. And it may be, for whatever reason, and genetics is probably a big part of it, some people have really tough beta cells, and they can handle all kinds of insults, inflammation, stress, and they don't get diabetes. And on the other side, some people have very delicate beta cells, and even the slightest insult, including a bout of uncomplicated mild pancreatitis that resolves, may end up with diabetes down the road. So this is, it's one of the great mysteries in this field. But clearly there's a wide range of susceptibility. Yeah.
So the other question is, I think that all patients with pancreatitis related diabetes deserve a consult with a diabetic endocrinologist. They're always brittle. Do you agree?
Getting at what we were just talking about, they're not all brittle. Fred and I, we've seen patients where, they've got chronic pancreatitis, they have diabetes, but we can just give them metformin and they do okay.
Yeah.
There's a whole spectrum. And then others, are, their A1C is completely out of control. If we put a CGM on them, a continuous glucose monitor, we see their glucose is ranging from 50 to 450. And then there's everything in between. So they may be brittle, but they may also, be fairly mild. Those are the lucky ones. But there's a full range. It's really quite fascinating. Great question.
I think that's the last question I see here. Yes. Well, thank you, Mark. It was outstanding.
My pleasure.
I would like to thank everyone who attended the session tonight. And the talk will be available at the CAPER website, and there is a link in the chat notes where you can find.
All right, thank you to the speakers and moderators, and thank you everyone for attending. Next week will be the last of the 5 sessions at the same time, 8 p.m. Eastern on Thursday night.
Thanks a lot. Appreciate the
Thank you.
invitation.